I think it's been clear that we haven't had it as bad as the hospitals in the city. We've been trailing a little bit behind in terms of the numbers. I think also I'm down in Central Jersey, so a solid hour drive from Manhattan. The numbers in our hospital, which is nearly an 1,000-bed hospital, so it's a big hospital, Robert Wood Johnson. It looked like the COVID positive numbers really plateaued in the 230 to 250 range, almost a quarter of the hospital, with around 60 to 70 patients in the ICU. And that's, my understanding, is very close to full capacity. I think about 80 to 90 ICU beds. That plateau was reached a few days ago. And it looks like over the past couple of days, the number's now gone down to around 170, 180 COVID patients. So, speaking from our hospital experience, it appears that our hospital's done a very good job, I think, both in terms of leadership, in terms of kind of managing the surge, allocating healthcare personnel, PPE. It seems like they were fairly ahead of this wave. I do know other hospitals in New Jersey have gotten hit a little bit harder. I think it's a little bit of luck too. Good luck on our part and bad luck on their part, just in terms of kind of what was going on in their immediate environs in terms of patients coming through those ERs. And I think the patients, understandably, or the hospitals rather, closer to New York, in northern Jersey, probably a little bit more impacted than us. So, but it's still very much kind of a lockdown situation. It's still, still quite a huge percentage of the hospital is kind of cordoned off to deal with these patients. And, but yeah, in agreement with what you're saying, I think it looks like probably in the next couple of weeks, and a lot of this depends on what the governor's mandate, what happens with that, because currently there is a mandate suspending elective cases. There's a mechanism to get truly urgent cases done, but it's, it involves filling out a form and appealing to basically these kinds of makeshift committees within the hospital. But it looks like there'll probably be some normalization in around a couple of weeks.
Yeah. Mike, what about you?
Yeah, same thing. We really haven't been hit as hard, luckily, as the tri-state area. And, down here in Miami, we have five hospitals in our system that kind of span a large area in South Florida. And so it's been interesting to see how the numbers kind of fluctuate between the different hospitals. Sometimes it's not really correlating to the population, but more to maybe the number of nursing homes around that hospital, things like that. But overall, it's been very impressive to see the hospital mobilize in order to get, a large amount of ICU access beds available and increase our capacity in ICU beds, even more so than I expected. Jackson is one of the largest hospitals in the country, and we only got to about 30% of the capacity for COVID patients that we could have gotten to, which was reassuring. I think the most interesting part is just really with the testing. I think right now it's much more comfortable being in the hospital because we have so much access to testing here. Just a few weeks ago, it was kind of, we knew who the symptomatic patients were, but we really didn't know the asymptomatic patients. But now we're testing everybody that really comes in the door in the hospital for any reason. And so it's very reassuring as far as the patients go, the staff, the technicians, and the doctors to know exactly who is possibly infected and how to isolate them. And so it's a much more organized kind of setup that we have right now. And everything is very isolated. Different areas of the hospitals are kind of identified for COVID. And we're reassured that that's true based on the amount of testing that we could do.
Yeah. So it seems like both of your institutions then kind of took what they saw, what happened in New York, and made responsible changes to keep patients safe throughout the system, right? You have COVID positive, COVID negative floors. We're doing that as well with Lenox. And as we look towards recovery, we have COVID positive negative ORs as well. And so there's a lot of mechanisms that have been devised that, are keeping people safe, which is, critically important. What about brain surgery? What about brain tumors? Over the past, 56 days or so, have you guys been operating?
Yeah, it's been on a very selective basis. I would say, overall, it's been maybe around a surgery a week for me. These, and I'm sure Mike has observed very similar things, Randy, to what you've seen, which is that patients are really not seeking clinical attention for their symptoms. And so you have kind of a breakdown in the normal in the normal system, the normal routine, which is that patients who have symptoms either go to their primary or whatever physician. They end up getting an MRI. We know a lot of that is kind of been suspended, not officially, but that's, it's not really being done with any kind of regularity. And the bar is even higher for patients coming to the ER. I mean, I did have an operation yesterday, and it was on a patient who was elderly in his late 70s, who lives alone, and who was noted probably as recently as early March to have had some language symptoms, not really speaking as much as he normally did by his son. Those got a little bit worse to the point where a couple of weeks ago, the son encouraged him to go to the ER, but the patient would have none of it. Just very afraid of COVID, understandably elderly. The guy wouldn't even step out of his house. And finally was basically found kind of catatonic mumbling and had just a massive multifocal glioblastoma when he came to the hospital and got imaging. That's kind of the circumstances in which I'm seeing patients, just pretty progressed symptom-wise. They've kind of let it go. They don't want to come into the hospital. I know we've seen that beyond just even tumors. I know this is a tumor-specific discussion, but we've heard a lot of that in the stroke world too. People just either being found dead or hemiplegic, some kind of incredible circumstances that, were kind of unimaginable before all this. So, yeah, so in these situations, I've seen these patients, obviously. In that particular case, we just ended up doing a biopsy, but I've had a couple of the cases where, we've done, more traditional, true, tumor removals, et cetera, but it's been infrequent.
Yeah. Mike, how about you?
Yeah, I'd say, similar. I think that the number of cases presenting with brain tumors right now is definitely low. My practice is primarily skull-based, which deals with a lot of benign tumors that are at the bottom of the skull around the cranial nerves. And these are typically more slow-growing tumors that have very slow progressive symptoms. And so it's been interesting to find that balance of, when do you decide to move forward towards surgery or not in this time period. It's a combination of discussing with the patient their concerns, understanding the resources that are available literally day by day, for that surgery, how many days and how much, resources that patient would need while they're in the hospital, and then who's at home with them to support them during the recovery. We're finding slowly the physical therapy teams and resources are starting to move towards Zoom webinars where you can do physical therapy at home for some of the patients. Yeah. But that's important to kind of figure out before you make that decision of who should come in to get a surgery, because then what happens after the surgery, and making sure that everything is lined up is good. And so for my skull-based patients, I find myself, where I used to meet them once, we have a long discussion and then kind of make the decision, this is what we're going to do. Now I find it as it's almost like multiple short kind of telehealth visits where we kind of talk about each one of these steps and kind of make a logical decision based on what's happening when to do the surgery. So in that regards, it's good because you get to know the patient maybe a little bit better in some respects, and you talk about the entire plan up front. And so I think we try to be, as educational as possible. The patients that we have been operating on, just like Simon has said, have been all the ones that have been very obviously progressing with severe symptoms or have a tumor that we're worried about moving fast. I had 4 endoscopic cases last week where, all patients that had vision loss and had to be operated on fairly urgently. So those things I think are more clear cut, but it's for my practice, especially, it's the benign skull-based patients that are a little bit more interesting of a dilemma going on right now.
That's great that you bring that up. And actually, I know, Simon, you do a fair share of pituitaries. John, you do a ton of pituitaries and skull base. What specific precautions do you have to take with skull based cases? Obviously, the ENT folks have brought up this idea of increased viral load in the nasopharynx and maybe more exposure to the staff in the operating room. Does it change the risk to the patient? Does it change the risk to the staff? And what precautions have you guys taken about this?
Yeah, I think that. Yeah. Oh, go ahead, Simon.
No. I was going to defer to you guys because I actually have been fortunate enough to avoid the circumstance. I haven't had to really take anyone in who had progressive visual loss. I haven't had to do anything through the nose over the past few weeks. So yeah, so whatever you guys have experienced, I benefit from as well.
Yeah, I mean, I think preoperatively, we've been taking the stance that we do 2 tests. So one several days before, and then we have the testing ability to do one like the night before surgery. So you have 2 confirmatory tests, which helps with the team. The other thing that was interesting is, we've had a couple very vascular tumors. We had a JNA, which is a very vascular kind of pediatric anterior skull-based tumor. And there's a risk that you can lose blood, and there's a blood shortage going on right now. So things that you sometimes wouldn't have to think about, we really needed to make sure that the hospital was prepared for something like this, questions that we wouldn't normally have to ask. So you always have to make sure the team and during surgery and after surgery is ready. And then during surgery, we are still treating everybody that we're doing endoscopic or any temporal bone drilling as they would be positive. So we use either N95 or P100 mask with full face gear. And we're trying to experiment with different draping procedures now to try to minimize the aerosolization of the bone dust.
Sure. John, anything you want to add to that?
Yeah, I like the point where presume positive is the motto. And whether you're doing endoscopic or skull-based temporal bone drilling, or like you did today, drilling out the optic nerve, you get a single aerated cell and you're exposed. So I think PPE is going to be paramount, making sure that all of our staff in the operating room are fully covered. We have experimented with this 3M drape that we drape and we tape to the forehead, and then we drape it over the face for every case. And obviously that doesn't prevent you from getting an aerated, frontal sinus or temporal bone air cell. But again, just being absolutely aware of the fact that no surgeon should be in the room during intubation and extubation, minimize the amount of personnel that are in the room. Extubation in particular is the highest risk, and make sure that your mask fits, that you have facial covering. We do a test within 24 hours for our patients, and it's important that our patients know, and I missed the earlier part of the conversation, is we are taking their safety, and having had so much experience with COVID, our hospital now knows exactly how to sort of isolate the non-COVID people, and really with all the testing that we have, both from a PCR perspective and the antibody testing, we have basically half a hospital that's free of COVID and half a hospital that is filled with COVID, and that balance is going to be the way every hospital in America is going to do surgery for the next 6 months, and just making sure that people don't lay down their guard. We unfortunately had a neurointensivist who got sick this week, and we're basically 7 weeks in already. Not to say that he laid down his guard, but all it takes is to take your mask off next to somebody who's 3 feet away from you, and you can be exposed. So it's somewhat common sense, and we take every patient as presumed positive in the operating room.
Yeah, absolutely. So I mean, listen, the news has been positive lately, right? Cuomo gets on there every day, tells us just hold tight a little bit, but if you look at the actual numbers, we've reached that plateau. Maybe we're coming down kind of the other side of that wave at this point. What does recovery look like in your different regions? I know for Lenox, we've got specific criteria. We have to wait for the state to obviously give permission to fully open up, but we've started kind of ramping up a little bit, specifically doing urgent cases, or the more urgent cases, not just emergent, finding time. And it's really, keeping an eye on resource utilization. We've kind of touched on that a little bit. Resource scarcity, making sure we have ICU availability and staff availability. But what do you guys have planned?
Yeah, I mean, I think the same thing here. We're starting to ramp up at the different hospitals slowly. I think the bar of what is an urgent surgery is going down. And the plan is to start, considering elective cases, kind of planning them out for the next week or two as the mandates kind of lift. And, and that will help in a lot of ways. I think right now what we learned the first time around is really, how quick can you free up resources? What resources do the hospital have, and how to allocate those resources quickly? And so knowing that, I mean, I think we're a little bit more comfortable with filling up the gap of the open space of the hospital now to a certain point. And that's what everybody's trying to figure out. Okay, well, if 60% of your hospital's free and open, how much reserve do you need in case the spike starts to happen again?
Mm-hmm.
And, and what numbers do you go by? Do you go by the number of positive cases? Do you go by the number of admissions? It's a difficult thing to do, but I think that's what we're all watching.
Yeah, absolutely.
Yeah, it's a bit of a moving target. I mean, for me, it's been fairly black and white in that the cases that have taken, I think, are very obvious cases of bad malignant disease, or I had a large thoracic schwannoma as well, and a guy in his early 40s who had very significant, basically developed a sensory level over the course of days. So I guess just for me personally, it's worked out. I mean, the cases have been fairly obvious, and I really didn't get much pushback after submitting it to these kinds of committees that are now in place, both within our department and even just among the OR leadership, which is basically comprised of a few physicians, few surgeons, and a few senior surgeons representing a few fields. But yeah, I mean, I think it's going to be kind of the way Mike described. I think it's a bit of a moving target. It probably will be incremental kind of opening of the sluice gates and not just a complete kind of dam break. And I think a couple of other good points have been made that were a little bit novel to me. I hadn't considered it in this way, but sure, we have a backlog of cases, but we're starting to get concerned, and we've heard from other people, other neurosurgeons, that is, across the country, that as their restrictions have really already lifted, they've noticed that their elective patients are not wanting to have surgery. So again, for us in the brain tumor world, it's a bit different. I definitely have some cases on that I had scheduled kind of late May, June. Couple of, ironically, just two intraventricular meningiomas that were both asymptomatic, that both demonstrated growth. So those people wanted the surgery kind of late June when I saw them about 2 months ago. I don't know what those patients are going to end up deciding now when I re-engage them after all this. Some of these people may bail. They may want it in the fall. They may want it somewhere else. So it's not a guarantee that all of a sudden there will be kind of an onslaught of these patients. In the non-tumor world, I think what I just mentioned probably is more broadly applicable. And those are the neurosurgeons we've talked, cervical disc, lumbar disc, what have you. Some people might get symptom improvement. Some people might just say, forget it, I don't want the operation. That's a little bit trickier. But in the tumor world, in those specific kinds of cases where they're not symptomatic, they're kind of growing, I don't know what's going to happen to those patients. And I have probably somewhere between 3 to 5 of those patients on my schedule. So it's not a huge amount, but it'll be interesting to see kind of how they respond.
Yeah, I think, that's kind of the impetus behind why we did this conference as well. So patients tuning in, people tuning in can see that we've made moves. The hospital is not necessarily the most dangerous place you can be right now. The subway might be, your home might be, but not necessarily the hospital. I mean, we've learned from this experience. We've, shared that knowledge, at least coming out of New York, with other hospitals that have done a great job, where they were predicting 120,000 people infected here. We've limited that by following the rules that were set forth. And the same way goes, or the same conditions hold in a hospital setting, where we've made, we've enacted measures to keep patients safe. And as long as that message gets put out there, there's certainly an increased risk by walking into a hospital. The person next to you might cough on you, but in general, patient safety is paramount. And we all understand that, I think. John, anything specific with Lenox that, we're doing that I haven't mentioned?
Well, let me just give you one fact. The Lenox Hill Emergency Room currently, which is the third busiest emergency room in Manhattan, is at an all-time record low for admissions, even pre-COVID. So now that the COVID nadir, we're approaching the first nadir of COVID, the ED is at an all-time low of visits. That means COVID is now waning, which is great, but patients aren't coming through. And that means they're still, obviously here in New York, we're still on shelter in place but it's a very interesting phenomenon. We've all heard the statistics of coronary events and even cerebral events diminishing over the last 7 weeks, but we are at an all-time low for ED visits. So that means our patients with brain tumors, maybe undiagnosed brain tumors, are obviously resisting getting medical attention. Obviously, the primary care docs' offices are not open. The melanoma doctors' offices may be open, but they're on reduced staff or staggered work from home policies. Women are not getting mammography. I mean, there's a whole backlog of oncology that at Northwell we see 16,000 new cancer cases per year, and it basically was shut down for 6 weeks. So those are big numbers that are going to be coming through in the summer. So don't expect to have your weekends off, I think, in the summer.
We talked about it a little bit during our last webinar too, whether or not this is going to translate into worse disease when it comes back. Now, obviously, Mike, you've been watching some of these skull-based cases. They grow a little more slowly. Patients develop symptoms kind of after they fall off a cliff, or they're manageable symptoms for now while they wait for this period to end. Do you guys think that you're going to see larger brain tumors, more significant symptoms that are going to change the way a patient's treated or their outcome?
Yeah, definitely. I mean, I think that there's, without access to getting images and access to physicians, especially here in Miami, we're kind of in a unique area where we get a lot of patients from the islands, from the U.S. Virgin Islands and from Puerto Rico. And we just had one today that diagnosed at one of the islands with a large meningioma, symptomatic, but they can't find a flight or a boat to bring them to Miami. And there's nobody there on the island to treat them. So it's going to be very interesting to see how the next couple of months play out and what happens. I think it will be kind of a slow trickle. I don't think it's going to be a sudden raise, but eventually it's going to get very, very busy. I think what people really need to think, though, is that, we're very far away from eradicating the virus. And so the idea of I'm going to wait till the hospital is free, or I'm going to wait till the virus is gone to have my tumor surgery is not really, the realistic approach. I think, it's a new world that we're living in. And like you said before, it's reassuring that a lot of the hospitals now have caught up or have the situation under control, are tested. And the hospital is a very safe place to be. And so, being at home, having your tumor worsen or your symptoms worsen could put you in a position where that is not reversible. And so it becomes now that the risk of not doing anything is more than the risk of coming to the hospital, for sure. And I think that risk is at the hospitals even going to get lower as we learn more each day.
Yeah. Simon, anything else?
Yeah, I mean, I think you make a great point, Randy, about kind of reassuring the population, if you will, because the perception is going to be negative, and negative specifically with respect to the potential for contracting the disease if you come into the hospital. And probably the odds of contracting it are incrementally more than, like you said, going on the subway or something like that, if that. And so the hospitals are probably going to make moves to try to win back the trust of the population. I don't know if it's going to be with marketing and advertising or things like this, or some combination of those factors. But I think that that's going to be important, because obviously doing these operations is very important for the well-being of the population, and also critical just for the economic machine of the hospital. I'm not talking about that in just terms of dollars. I mean, patients need to come in, have surgeries. Surgeries are the lifeblood of the hospital to allow patients to get care in other fields beyond just surgery. So it's a crippling thing in many phases of the game, many aspects of how the hospital runs. And I do agree, obviously, people are going to be coming in. I agree with John. I mean, I think, and Mike too. I mean, there's going to be probably an onslaught of patients after this kind of backlog of MRIs gets done, or patients are, feel a little bit more liberated and they come to the ER. And you're going to see probably a proliferation of these kinds of cases, or people who, are maybe a little too progressive even for surgery. I think a couple cases that I did just happened to be multifocal glioblastomas the past couple of weeks requiring biopsies. But maybe in 2 months, if those patients come in, I would have said, hey, this patient probably would have come to clinical attention in April. And I mean, it may not have been the case, but it definitely will raise that question. And I do think that people are going to be fairly progressed with some of the malignant disease and the skull-based tumors.
Yeah, I think it's important too for people listening. Your functional status, your ability to take care of yourself matters with your outcome. And so if you are having symptoms, you shouldn't sit on this, right? The better you are after the surgery, which usually reflects how good you are before the surgery, really does matter in terms of what chemotherapies you can get, how well you're going to tolerate them, how you're going to do functionally and tolerate the procedure and the disease itself. So it's really critical, if you are having symptoms, to get seen. And that kind of brings me to my kind of last point, which is, again, as we enter recovery, what does your office look like? How are you guys able to get patients seen? How are you getting them through MRI? We talked a lot about surgery, but what about the actual office?
Yeah, I mean, I'll start off real quick. I think we probably were all in a way a little resistant to doing telehealth, but that has been fairly seamless, that transition. And I do think it's changed the way we've counseled patients. I think it makes it easier. It's not as kind of one formal sit down where you get everything out. And it can become a more kind of segmented thing, the way Mike was describing earlier, where it still very well might be one visit, but because it's so easy to do, it might be a phone call or another telehealth visit. And so that's kind of changed. And I think those things very well might have legs. We all have our versions where we call patients after an in-office visit to provide additional reassurance and information. I think most of us as neurosurgeons are probably fairly resistant to that. I think this has probably changed our attitude towards that level of interaction. It's made us a little bit more interactive. It's made us a little bit more accessible. And I think that's probably a big positive for patients. Seeing patients physically in the office, I'm sure it's going to be awkward initially with masks and not being able to shake hands. Those social mores will have to still be kind of suspended for a while. But yeah, I mean, I think things will probably normalize on that front fairly quickly. But telehealth, I think clearly the advent of that is a big change.
Yeah, Mike, you guys have a big infrastructure. How about you? I'm sure.
Yeah, I mean, I think that University of Miami has done a great job with putting the telehealth together, and looking at the numbers, we get them every week, that we're almost about 70% back to where we are with our clinic visits by telehealth now, pre-COVID, which is great news as far as being able to get access to the patients. And those patients that I've seen in clinic have been working with it very well, and they've been positive experiences. I still think we don't get as much information from our patients by telehealth, and so we have to be careful with that. And it is not quite as efficient as much as I thought it would be. The visits tend to be maybe a little bit shorter, but there's a lot of back and forth that needs to happen after and before the visits that could happen now during your visit. So I think that needs to be optimized a little bit more as we go forward, especially as we get back up to 100% capacity. But I agree with Simon in that this is going to be part of the new way. Telehealth is not going away. I think it's a blessing for many of the patients that travel and come from far away, or people who don't have access to transportation. But I don't think it should replace the old way per se. And it's going to be a fine combination between the two moving forward. And that'll be interesting to see how that plays out.
Yeah, I know. I mean, I can speak briefly about Lenox. I'm going to have John weigh in too. We're working on kind of making that transition as seamless as possible, that integration as seamless as possible, right? You need to be able to have both options there. Maybe the elderly population doesn't want to or is unable to participate in telehealth as well. But we found actually that most people are pretty amenable to it. Their family members can join on from wherever they are, help with both translation services, even though, you still need a formal translator, as well as just ingesting some of that information, especially big information. We have a lot of moves going on. John, you want to weigh in at all with kind of telemedicine in the future of the Lenox office?
Yeah, I mean, I think we're reconfiguring our entire office, everything from future plans to get rid of a waiting room to really have minimal interaction to the advantage of the glioblastoma patient in particular, not having that patient necessarily come in as often as they were coming in, making sure that, I mean, as much telemedicine, and obviously David Langer and his emphasis on information technology with his company Playback Health has integrated into our EMR and into our telehealth progress. But I got to tell you, even our nurse practitioners now, we are using them via telehealth as first-line providers. And I think it's liberating me from to do different things. The patients really love it. I can get pinged at any time during one of these visits and pop in and out with my mobile phone now. And I can be at home, I can be in the operating room, and literally just ping in and out of a telehealth visit with my nurse practitioner. So I think we're really reconfiguring our entire workflow now based on this in a good way to make it as little sitting, waiting, filling out paperwork as possible. So it's a work in progress, but we see the silver lining, like you guys said, in making this a more efficient system. and really to keep our patients out of the hospital, to keep our patients from traveling. You know, these glioblastoma patients, Randy and I have an interesting project about glioblastoma patients and COVID, and whether we think there's actually a protective effect of the lymphopenia that we see in glioblastoma patients and COVIDity. But obviously we want to keep our patients safe, like you said, and keep them out of the hospital, the medical system as much as possible.
Absolutely. All right, guys, we're at our 32-minute mark. So I like to end these things, first of all, obviously by saying thank you for your time. Fantastic discussion, I think. This will get posted on the YouTube channel. You can share it with whoever. And we're going to actually talk, Mike, you have a webinar tomorrow. You got a whole series of web-based events coming up, but I know tomorrow we're doing a global tumor symposium. Jacques Morcos is going to be the kind of discussant and going to talk about orbital tumors, right? And his approaches to that. And it's going to be interactive. You want to say anything specific about it?
No, we're very excited. I mean, it's going to be a really interactive way to kind of unite a large audience to educate people about very specific details about surgical approaches and resection for different kinds of tumors. And we're starting with our own skull-based expert, Dr. Morcos, tomorrow. I think the following week is going to be Dr. Spessler. So we're very excited and trying to, kind of one of the great things that have come out of COVID is this ability for everybody to kind of educate each other with webinars and kind of broaden their range of reach by using the internet. So it's been great.
Yeah, absolutely. And obviously it's going to be a little bit more technical of a talk than this one is, but I think, you know, as many people as want to can sign in and see video and hear great discussion with, you know, very pioneering people in their field. So
exactly.
We're going to post the link here in the chat in a second, but otherwise, again, appreciate everyone's time. We'll talk soon.
Okay.
Thanks, Randy.
Thanks
Randy, for having me.
I'm going to post the chat right now, the link to sign up for the webinar tomorrow.
Perfect. Thanks, Laura.
You're welcome.
Take care. Thanks, Laura.